Assalamu alaikum. So today I'm going to discuss an unedited routine case, phacoemulsification. So this is a medium density cataract making the main incision. So the blade in this case was a little bit blunt, and so it required some effort to make the main incision. There is some pooling of fluid at the medial canthus because the eyes were a little bit deep. So injecting some xylocaine by the adrenaline, and now I inject some viscoelastic into the anterior chamber. So you will make a limbal main incision, and see here I have made a slightly larger side port, and the tip of the 11 number BP blade is a bit blunt, so it accidentally made a larger side port than I would have liked. But anyways, now I move on to make the capsular axis, and so this is a completely unedited case. The left eye of the patient. So I am conscious of the size and centration of the axis. I'm hoping that it will overlap the optic 360 degrees and it will be adequately centered. Now moving on to hydrodissection. First on one side, tap the nucleus, then on the other side, and after a few attempts the nucleus spins. So the mobility of the nucleus is important as it will make subsequent steps much easier. Now take the phaco probe. Clean up the superficial cortical material, and try for a primary chop, a direct chop maneuver. However, I am unsuccessful, so I bury the phaco probe again into the deeper part of the nucleus, and here I am able to divide the nucleus into two heminuclei. Rotate the nucleus, bury the phaco needle into the other heminuclei sufficiently, and here I am able to separate a piece of the nucleus using the dialer to create space so that the small piece can come out. And I usually pull a small piece out to create space in the bag. Now as you can see, the side port, the iris has prolapsed. This is because the side port was bigger than it should have been made. It's slightly bigger, so the iris has prolapsed, and so you should check the tip of your knife before making a side port. If they're blunt then and the sides are sharp, then such a situation arises. So nucleus management is going as planned, and finally the nucleus has been emulsified. So this was the prolapse of the iris from the side port left a bad taste in my mouth. In such cases, the iris which prolapses to the side port normally atrophies, so it is better to be very careful when making these side ports. Now using a Simco cannula to take out the cortical sheets, and now the margins of the rhexis can be appreciated. I usually use the main incision to clean the sheets which are sub-incisional, to the side port. The rest I remove through the side port incision. So nearly done. That's it. Trying to clean up the entire margins of the capsule. Some little bit cortical material left, cleaning it up nicely. Some residual cells left on the posterior capsule, polishing them because I do not want this patient to undergo YAG capsulotomy. So in my experience, polishing the capsule decreases the risk of a YAG capsulotomy procedure. Now enlarge the main wound to a 5.5 millimeter wound so that a hard PMMA lens can be inserted into the eye under irrigation. Slightly more challenging using the non-dominant hand to perform these maneuvers. Here I will do so. Now all that's left is to dial the IR into the capsular bag, the leading haptic, and have to be careful at this point that you do not tear the posterior capsule. Okay, so an unsuccessful attempt, but still trying again. A little bit challenging using the non-dominant hand. And here, so alhamdulillah, it seems to be overlapping the optic nearly 360 degrees.